Welcome back to Medicine Made Easy with me, Kavitendra. Now we're going to discuss the management of ROP. If you have not subscribed our channel, do subscribe for more interesting videos like this, and as well press the bell icon so that you will receive regular video updates, and you can share this video to your friends so that we will learn together. And in previous video, we have discussed in detail about the pathogenesis, the clinical presentation of the ROP, that is retinopathy of prematurity. In this video, we will discuss about its management. If you have not watched the video 1, I've given the video link in the description. You can check it out. Now, basically, management, what are we going to do? We need to do first prophylaxis and then screening and follow up. Then it is treatment. What is the prophylaxis? If at all a baby is in oxygen supplementation therapy, then oxygen concentration should not be more than 30%. That's one point. And we should avoid apneic episodes and we should avoid the infection in the baby. This is the prophylaxis for ROP. Now, coming to screening and follow up. How to screen? Remember, invariably we know for less than 34 weeks of gestation, the baby is born, or the baby is less than 1.75 kg, that is 1750 gram baby, we need to screen. Now, what is the idea behind that? Remember, in previous video also we have discussed, normally by 32 weeks, that is by 8 months, the nasal retina is vascularized. That means the vessel reaches the nasal aura by 32 weeks. The temporal retina is vascularized completely after 1 month of the birth. So it means if at all the prematurity is happening, this process of vascularization is impeded, and that will in turn cause a pathological change after oxygenation will result in fibrovascular proliferation. So we need to screen the babies. No, that is why we need to do screening, and it is ideally going to start less than 34 weeks. Remember, and after the period of viability or before the period of viability, just have this in mind. Like we have studied in OG, right? We'll take 28 weeks. That is period of viability in India. So 28 weeks till term. That is completed 36 plus 6, 36 weeks plus 6 days in the week. So take that way. 28 weeks less than 28. That is less than 28 weeks. 28 to 34, no? 20 to 34 weeks. Then 34 weeks to 36 weeks plus 6 days. This is what it is. If all a baby is born less than 28 weeks and it is a birth weight of less 1.2 kg, then at 2 or 3 weeks age, we need to screen with indirect ophthalmoscope. The first ocular examination with indirect ophthalmoscope for screening of ROP for a baby of less than 28 weeks should be done at 2 to 3 weeks age. Okay, then it is 28 to 34 weeks. Then it is the baby should be screened at 3 to 4 weeks of age. Then it is 34 to 36 weeks. See, we know after 34 weeks, no? See, basically after 32 weeks, the vascularization of retina, that is nasal side, is okay. But then we need to screen. Why? Because if at all the baby is high risk, it has high risk factor exposure, that is prolonged oxygen therapy, hemodynamically unstable, that is shock, acidosis, mechanical ventilation, then it can have the risk of ROP. But majority of time it can regress, but then still we need to screen. Okay, that is the idea, because even the temporal retina is going to vascularize 1 month after birth. So you need to screen. ROP screening of the neonates is very important. Now coming to follow up. Whom to follow up? Remember, we need to pick up the case very early. That means stage 1. What is stage 1? Yes, it is a demarcation line where we have a vascular retina and vascular retina, right? So we need to take it as stage 1 itself. We need to pick the baby and follow up. That is, if it is a zone 1, that means what? Severe disease. So we need to follow up the zone 1 or zone 2. And it is a non-plus disease, follow up. If it is a plus disease, treat it. There is a big tabulation which is given, and I've just made simplify this tabulation only. So at stage 1, pick up zone 1, zone 2, see whether the pathology is non-plus disease, then it is follow up. This is plus disease, then treat it. Simple. Now coming to treatment protocol, which is given by ETROP, that is early treatment ROP study. Now there are two things. One is laser therapy and surgical treatment. They have said laser therapy is more good when you compare to cryo. So we are not doing cryo, laser therapy only. What laser we are going to use? It is diode laser of 810 nanometer or double frequency ND-arc laser 532 nanometer we are going to use. But not only the laser, we are going to use with a laser indirect ophthalmoscope. Now we use this laser to whom? We need to do for pre-threshold high risk, right? We remember pre-threshold high risk people, that is, see here, zone 1 plus disease, zone 1 non-plus stage 3 disease, zone 2 stage 2 stage 3 plus disease. This is all high risk pre-threshold disease, which we have discussed in previous video, right? They need laser photocoagulation. That is what we need to do. here. Right, next is threshold disease. Next is rush disease. So that's what it is. So after laser therapy, what you need to do, we need to give antibiotics and steroid. As we know, even after the radio, so the laser, no, there will be intraocular reaction is happening. Inflammation can happen to that. We need to give topical eye drops. Then we can give antibiotics for 1 week. Then you need to follow up the patient after 3 weeks, 6 weeks, and 12 weeks. This is laser. Surgical treatment such as lens sparing vitrectomy with endolaser photocoagulation is done, and then retinal detachment management. No, when does retinal detachment happen? Yes, it is the stage 5 disease. Okay, in stage 5 it is total retinal detachment, and stage 4 of ROP is subtotal retinal detachment. That is stage 4A is not involving fovea, that is extra fovea. Stage 4B is including fovea. So hope I made the points in ROP more clear. Thank you so much for your patient listening. We'll all meet in the next video. Till then, stay tuned.